So I'm going to try to, in this innovation section, talk a little bit about innovations in imaging, but specific to my particular specialty in a practical way. So I'm just going to discuss a few things. So first and foremost, my disclosures, I'm the inventor of some of the technologies. I'm going to show you at least one of them, and I've participated in some NIH research as well, been a consultant for many. This is a picture of the modern bronchoscopy suite. You can see that it is heavily integrated with multiple kinds of imaging, endoscopic imaging, ultrasound imaging, and different kinds of x-rays. And we can integrate these things all into one procedure to give us a seamless environment in which we can work. I'm going to give examples of three different variations of using imaging. One is for how we use quantitative imaging, which always in my mind seemed like sort of a science fiction idea, but we can actually use quantitative imaging. And we're going to show you how we use imaging with the integration into navigation systems, particularly with robotics and mobile CT units. And then I'm going to show you an application of 3D printing for patient-specific implants. So the first is just this very simple paper. It's actually not a simple paper. It's a very complex description of how individuals and radiology departments ought to be reporting different kinds of imaging technology. So if you want to take some of this back to your home institutions, this is a great reference. It's a specific reference about how individuals should report and how they should put together these different kinds of imaging modalities. It talks about CT and functional MRI and a number of things. And you can see here that quantitative imaging is not a new concept, but it really is applied now that we can look at different disease structures and measure things in the lung structurally and functionally, depending on which technology. And we can not only make diagnoses, but we can also quantify the severity of these diseases. And of course, look at them over time. Now, as a particular case, when we use bronchoscopic lung volume reduction in the United States, there are two different valve technologies approved for use. The requirement to use these valves is that the lobes of the lungs have to be severely destroyed. It has to be emphysema in a particular area of target, and you have to be able to treat an entire lobe. And the lobe is important because you can't have collateral ventilation. So therefore, if you've got a severe amount of emphysema and the lung air can extract and move from one part of the lung to another through back channels, pores of Kohn, for example, then the lung volume reduction won't work because the valves will be letting air out of the lung and it'll just backfill from another direction. So sometimes it's difficult to find that, and so we use quantitative imaging to do these sorts of things. This is a very dumbed down version of what these images look like, and we get this report. This is from a company called Stratix, and they work with one of the valve companies. And we can look at the CT, and it quantifies for us where the areas of disease is the worst. It shows us what volume is there, and it also gives me a sense of whether the fissures are intact from one part of the lung to the other. And so when you interpret this report, first of all, you'd see that the black part of the lungs, in fact, are the worst emphysema, and you can see that the black lines represent that the fissures are intact. And then as a proceduralist, I would have to choose which part of the lung I would treat. And so looking at this, I can see that the right lower lobe is 71% destroyed versus the left lower lobe is 76% destroyed. And if I were to guess, I would be able to assess that the right lower lung was 2.2 liters and the left lower lung was 2.3 liters. And so I would target the left lower lung for my therapies. And then we can use the repeated imaging to go ahead and say, well, how much did it actually improve? So sometimes we can see just obvious evidence of atelectasis, but sometimes atelectasis doesn't occur. And so what we can do is repeat the imaging and see exactly how much lung has been changed, how much reduction of the volume of the chest has been done, and see if that correlates to lung function and particular patient outcomes. And this is just an example from the improved data looking at volumetric changes in the lung. Now, in navigational bronchoscopy, we have this ability to take the CAT scan of the individual patient and then go ahead and load it into a computer system. And then doing so, I can identify the target that I'm going to do a biopsy upon, get a three-dimensional image, prepare the procedure by finding a pathway through the airway and identifying. Then once I'm in the procedure, I can turn on the computer, register my position in the patient, and then use this computer screen that imputes and shows me the CT in multiple planes as well as a virtual reconstruction. And I follow the pathway with a catheter to try to line up my instruments to get a hold of that target. And you can see that I'm using visual cues. Now, there are multiple technologies in this space to show us how to do this. There's just using guide sheets and programming. This is a version from Medtronic called Illumisight. And what we're doing here is taking additional images and tomosynthesis, identifying where the target is in space. I can then do a little bit of a spin with the C-arm to try to identify its position. I can upload this, and then during the procedure, I can fine-tune the the feedback from the images to show me exactly where the lesion is in space. Now, there are other variations of this. This is an old paper around something called cone beam CT guided bronchoscopy. So in the interventional radiology suite itself, I can perform a bronchoscopy and then spin the CT scan to show me where the target is, and then use something called augmented fluoroscopy, where I identify where the target is. I could draw pathways on the screen and then identify where the target is, and then with the fluoroscopy, see where my instruments are relative to my airways and relative to my targets. And this has an ability to improve yield. This is a version of it that we use at the Cleveland Clinic, and it's just a robotic arm CT. I actually prefer the ceiling mounted unit. And the reason why is this video, you can see normally I stand at the head of the bed, but this just spins around the patient about 6 seconds. And in doing so, I'm able to look and see exactly where my instruments are in space. So actually, I've done my navigation, I found my way to the lesions, and I can precisely see if my needle or my forceps or my brush or my triple needle brush are actually inside the lesion at the time of biopsy. And doing this actually increases yield, although not always to 100%. You'd expect having this sort of feedback, we would have perfect answers. But again, the nature of sampling is that we're only taking small bits of tissue, so it's possible that even though I have this technology, I can't get an answer in every single case. Now, going down to the interventional radiology suite is not always very easy, so there are portable solutions. This is a device made by Siemens called the CIOS Spin. This was actually used for orthopedic surgery, but we repurposed it for lung, and this is a paper that we showed proof of concept where we can use this mobile C-arm to perform the same thing. And this is what it looks like. It's not as fancy as the radiology-based system, but you can see I have the C-arm around the patient, and I actually manually move it to its position. Then you see my fellow at the head of the bed holding the scope. What he's going to do there is, once in position, I'm going to hold the breathing. The anesthesiology stops the ventilator, and then you're going to see a very low spin of this machine. And so instead of that 6-second spin, this is about a 30-second spin. And so just a simpler instrument, something much more mobile and certainly much more cost-effective. But in doing so, I get a very similar series of pictures. Oop, you can see. And you can see with these images, I can show very clearly my needle passing underneath the nodule in this case, or the instrument up here or here. And so having the ability to use this in the procedure room in real time in a mobile system is incredibly valuable. Now, the problem with any of these imaging platforms, however, is that they're static. And so the CAT scans are not running simultaneously. So what you see here is the target on the screen, but you're also seeing diaphragmatic movement. And so you have to imagine, although these images are great in static motion, but the lung is also moving at the same time. And so you can see a disconnect between where the images are on the augmented fluoro and where the target would be in real life. And you can see that the line of the catheter here has been deflected by my instrument, but this is a little bit of a problem. And there's a technology out there that uses AI, not only to show its position, but to log in and register on the screen the position of the nodule as it would move in the patient. And so this is a technology called body vision. And you can see here the navigational bronchoscopies here, and then you can see the catheters trying to track along the proposed pathway. And you can see that it's moving with the patient's respiration. So this is actually pretty fancy technology, just incorporated into a standard C-arm. Now, in the field of robotics, there are 2 available in the United States, with theoretically a third on the way. And with robotics, we have the ability to do some really amazing things, where you can see here with the precision of a robot, I can drive out with a needle, and you can see an example here of using the needle to literally touch the eyeball on the bald eagle on a United States dollar bill. And so this sort of precision really changes the ballgame in terms of asking someone like me to go and sample a sub-centimeter lesion deep in the lung. Again, we don't do that very commonly, but when we are trying to find small things like cancers in the lung, when they're early stage and easy to cure, this precision is important. And here's a fantastic example from a colleague of mine showing a peripheral lung lesion right on the chest wall. You can see it's a small looking thing that very significantly risk for cancer. You can see in this case, the patient has very severe emphysema, and so the prospects of doing a CT-guided biopsy raise the risk of a pneumothorax somewhere from 25 to 50%. You can see with robotic controls, we're driving in the lung, and on the right side is the endoscopic images, and on the left side, you can see the computer-generated images from the CT scan, and with robotic controls, we're trying to follow that pathway. And the image above that, you can see the pathway we're following based on the planned procedure. And as you see here, we're going to drive through, and all of a sudden, things are going to change. And now this is what it looks like to look into the lung with emphysema. So this is not a common feature. We don't typically have scopes that go deep in the lung, but with robotic technology, we can go very deep and continue to see. And what you're seeing there is areas of space, this vacuous lung, areas of tuberculations, which normally would be vessels coursing through the lung. And we're trying to drive. So on the right, you see us trying to, or at least Dr. Pritchett here, trying to get around these little vessels. And you can see on the left side is where the computer telling us the lung cancer is. And as we're driving through this space, you can start to see something on the right side of the screen, this little purplish area. And as we get closer, we'll be able to get a good view of what this abnormality is. And you'll see the computer will start to help us load up. So you see it gets blue, and that area of purple abnormality is what corresponds to what's on the CT. Now we can go through there and put an ultrasound. You can see this radial ultrasound image out there. It's going to show an abnormality or a density that would normally not be present. And then we can do a small needle biopsy at that site. You can see that the catheter is bouncing a little bit with the needle. And in doing this procedure, it will make a diagnosis of adenocarcinoma. So there's a real-life example of using all the technologies together. And now one step further, this is a picture from a pig lab that we did where we used that mobile CT unit and a robotic system to drive in a catheter and deliver microwave energy. And so then we are now on the precipice, and the trials are enrolling for being able to perform microwave ablation of lung cancers in a bronchoscopic procedure, therefore avoiding the possibility of surgery or even radiation therapy. So very new, very exciting, and we'll see how it plays out. Now, the next series of things is around stenting. So one of the problems with airway stenting is that if you live long enough, all the stents fail. It used to be that stents were placed in people with terminal malignancies, but we're starting to see indications related to lung transplant and airway stenoses from benign disease. And so stents will fail over time. And you can see some examples of a stent that's being broken here in the top left of the screen. You can see a stent that doesn't fit with granulation tissue. You can see a stent here that migrated into the airway, one that was plugged up. And of course, here's an autopsy specimen of someone who died from a mucus plug. And so clearly stents have their problems. This is technology that was developed at the Cleveland Clinic, where I was an inventor. And so we've come up with a way of using the CT scan to generate three-dimensional models. And instead of what I used to do is hand make stents on the back table to try to fit, now we can use a 3D modeling program to generate a prescription and then do a pressure injection molding procedure. And this is what it looks like. We did the first case in humans in 2016, and I waited a couple of years to make sure the patients did well. But you can see that in the initial images, you can see all this terrible granulation tissue despite a handmade stent that I made. And then you can see the computer processing version up here. Once we get the CT, we make a three-dimensional prescription that converts into a CAD model, and that converts into an airway stent that we print. And this is what the computer program looks like. It gives the physician the ability to segment the airway, which is done by the engineers, and then we design the stent over the airway that we'd like to implant. This is a different version of this. This is a different company called Restore 3D. Theirs is unique because they also print their stent directly, and so this is a similar case of a transplant patient with an airway complication. And you can see in the future, we're hoping to get to direct 3D printing. Right now, where the FDA allows us to do pressure-injected molded silicone. This, however, I think is polyurethane, and this is just a sped-up version of a 3D printer making the stent directly. And so I'll just let this play out for a second. One of the reasons we can't make silicone directly is that it's an elastomer, which means it requires a curing process. You have to heat fix it, whereas this looks like there's 3D printed materials directly. The challenge, of course, is to make sure that they're light enough, small enough, and flexible enough to be able to deploy inside the lung. So there's just an example of one. Now, with the ability to get the CT scan and recreate it, we've been able to modify the procedure of designing the stent. And so in real time, I'm getting feedback from where the stent would be. On the new version of the software, I can size the stent based on the luminal volume that's given me by cross-sectional area and airway reconstruction. and then I could do a digital video, or say a digital virtual overlay of what the stent would look like in situ, and even give me the ability to detect side holes, where in this case, if I were to stent past the right upper lobe, it would give me a place where I know exactly where to punch the hole out on the stent on the back table. And then also, at the same time, I could take a look at the CT scan with the proposed stent in place, and that purple line represents the stent I designed, and it would show me exactly where it would fit in the lung. So this is a real step in the right direction for precision medicine. It gives me the ability to design exactly what implant I would need and where I would place it. And so just a very brief summary in the recognition of time is that quantitative imaging is very useful in guiding therapeutic interventions. It's now reached prime time and in FDA-approved products. We can use it to also correlate with clinical outcomes. The advanced imaging platforms are now integrated into endoscopic procedures and robotic procedures. When we bring them together, we have powerful tools to take on very complex diagnostic procedures, but now we're moving into the therapeutic realm as well. And of course, imaging-based prescriptions, the ability to make individual and patient-specific products is upon us, and now we can do those things in reality. So with that, I will stop. Okay.